Hello, my name is Sebastian Schneeweiss, and I'm a professor of medicine and epidemiology at Harvard Medical School. I'm also running a division for pharmacoepidemiology at the Brigham Women's Hospital. I was asked to talk about how we can come to causal conclusions on the effectiveness of medical interventions of prescription drugs when we use big data in medicine, also sometimes called real-world data. Here are my disclosures. You can pause the screen if you want to read this in detail. To set the stage, the 21st Century Cures Act in 2016 mandated the FDA to come up with a guidance document by the end of 21 on how the FDA wants to deal with real-world evidence with regard to regulatory decision-making about medications and medical products. These guidance documents are taken quite serious by the FDA. So in 2018, they released a framework, what they mean by real-world evidence. And two definitions are important in this document. One is what they call real-world data, data related to a patient health status and or delivery of healthcare, routinely collected from a variety of sources. So data generated through the routine operation of the healthcare system. Real evidence, of course, is then the clinical evidence on the effectiveness of medical products using such data. You can imagine that these very large databases that we have in the United States healthcare system, every encounter is recorded, and these transactional databases, they grow from the left to the right, and each spaghetti line in here is a patient that signs up with a practice and disenrolls the practice or with insurance plan. New information is entered every day. It's immediately sorted by the service date, which means that the databases, they remain dynamic at the right hand. So the first thing is what we do as research. We stabilize the data source in order to make the research reproducible. And then when you look at each of those lines, each of these longitudinal information records for each patient, well, in this patient, for example, you see that he or she was hospitalized, had diagnostic and procedure information associated with that, a prescription drug dispensing, a lab test done, drug, a visit with diagnosis, and so on. You can imagine the many different constellations. Once you have the data sorted in a longitudinal data stream, you can actually then implement a epidemiologic study in these data. Here's a cohort study where patients enter at the time of prescription dispensing. We follow them over time for any potential outcomes, and we look backwards in order to assess their health state and for potential exclusion criteria. Now, the research operations of a real-world evidence study in order to come to causal treatment effects, it's a quite linear process and very repetitive process. It always starts with a design layer. You have to pick the right study design that fits the study question. And these are either controlled study designs or self-controlled study designs that mimic the randomized versions of these. But here, of course, we deal with data that are non-randomized, that we observe in the routine operation of the healthcare system. After that comes the measurement layer, and that is quite complex. And you can simplify this by thinking about the four variable types that we really need. We need to identify the target population. If we're interested in patients with dementia, now we want to make sure that these patients truly have dementia. That is our target population. The exposure of interest, the medication exposure, a medical product, whatever this is. We need information on the study outcome, and we need, in the absence of baseline randomization, we need information on the confounding factors. And this can come from a variety of sources. This can be structured information, diagnostic codes, procedure codes, prescription drug codes, lab test codes, results, but it can be also unstructured information from medical records. It can be semi-structured information from imaging studies, and so on. You can easily imagine where all this information can come from. It requires quite a bit of pre-processing with machine learning, NLP, bioinformatics, and so on. But in the end, that's important, we need information on those four categories of variables. Once we have that, we can go into the analytics layer, where the main goal is to achieve balance between the treatment groups, treatment A versus treatment B, for example, and in order to mimic the randomization process that we all love so much. And that is often followed by sensitivity analysis in order to study the robustness of the findings. How susceptible are these analyses to biases that might be operating in the data, but also in our analyses. Now, we need to admit there is a lot of bad studies published in the space of real-world evidence, of these observational data studies that draw from this massive amount of information that is out there, that certainly don't lend themselves to causal conclusions. So what do we need to do? We need to be more transparent in our research so that other people can reproduce and can also check what we have been doing in order then to assess the validity of our research, in order then to decide whether they want to make a decision based on our research. In medicine, you want to base decisions on causal relationship, that a drug is causing the improvement of health, rather than spurious associations where you don't know, was it the disease that got better, or was it the medication that caused the improvement in health state in this patient? So causal relationships are essential in medicine. How do we get there? And how can we convince our counterparts that we are there? Here's an example, the OnTarget trial comparing telmisartan and ARB against ramipril, an ACE inhibitor, in order to establish non-inferiority between those two treatments with regard to cardiovascular endpoints. This telmisartan at that point was already marketed for about 10 years for the treatment of hypertension, but I wanted to broaden the indication. And FDA made them do this large randomized trial, costed in the hundreds of thousands of dollars. We, on the right side, we were tackling this problem by saying, look, at the point in time where OnTarget was submitted to the regulators, had we used with these big data assets that are available in healthcare and in medicine, had we come to the same conclusion at a much lower price tag and much faster, and also not exposing patients to randomization, to randomized trials. And as you can see in the yellow boxes, the non-inferiority was clearly fulfilled in a randomized trial, 1.01 as a hazard ratio, but we found exactly the same finding, and it came to the same clinical conclusion. Here's another example where we were in a very planned way, predicting a randomized trial, the Carolina trial. The Carolina trial was ongoing. It's a phase 4 trial of marketed medications, linagliptin, glimepiride, two anti-diabetic medications for type 2 diabetes. And we predicted half a year before the trial was completed that there was no difference in the cardiovascular risk between those two agents. But we also predicted that there is a benefit with regard to severe hypoglycemia for the linagliptin versus the sulfonylurea. That was in December 2018. And then in June 2019, when the American Diabetes Association had its meeting in San Francisco, the Carolina trial was revealed. And look at this, a very similar finding, clearly a non-inferiority with regard to 3-point MACE. And but also look at our prediction of a reduced risk for hypoglycemia that was also confirmed in the randomized trial, numerically slightly different, but that is probably due to different definitions of hypoglycemia. So that is very satisfying that we are able in some settings to predict the outcome of randomized trials. But why was it that these database studies came to the same causal conclusions, and how confident are we that the next time we do a study, they will get it right again? Right? How can we promise that? How can we have this confidence? And what do we love about randomized trials is, of course, the random treatment assignment baseline, the controlled causal study design in randomized trial, the temporality is all very clear, all the bells and whistles to reduce confounding and to reduce other biases, the controlled outcome assessment, and don't underestimate this, the ease of communicating the findings of RCTs and the ease of communicating the design and the causal interpretation of randomized controlled trials. Now, in real evidence studies or big data analyses, the world is different. We are struggling with any of these points, really. So we sat together with FDA and came up with a flow diagram in order to assess, what kind of studies lend themselves to real-world evidence studies, and how would we do these studies in order to get the highest validity out of these longitudinal big healthcare data. And the starting point is that you imagine the trial that you would like to do. Would you have the time and the resources to conduct this randomized trial? And this is what we call the target trial that you have in mind, where we have a washout period, where we randomize patients, the R for randomization, into an exposed group and a comparator group, often placebo, for pre-approval studies. Now, in a cohort study, the counterpart, the non-randomized counterpart, we also have washout periods or periods of non-use, S for selection into the exposed group or into the comparator group. This study design is called the new user active comparator cohort study design, with a bunch of advantages that you see on the right side that I'm not getting into here. We need software platforms that help us implement the target trial and not making mistakes and being transparent. We have a software platform here where we select patients in a reproducible way, where we select the comparison groups that we want to use. We select the treatment strategy that we want to study, the follow-up pattern that we are interested in. We select a risk adjustment strategy. Do you want to do propensity score matching? Do we want to do regression modeling to overcome the lack of baseline randomization? We do feasibility analyses and diagnostics. Do we think we can come to valid conclusions given the diagnostic feasibility? And then we run the analysis. We get a comprehensive report of all that we have done. While we are doing this study in the software platform, we can let the platform tell us exactly the statistical analysis plan, for example, in plain English, in a more structured form, looking at all the variables, and you can break it down even further in exactly the codes that were used in order to define these variables. Remember, the measures layer, where all the action is happening. The measures layer is the most critical layer. We also want to provide audit trails, particularly when we want to go to regulators, when we want to have a real impact on the community. We want to allow people to look over our shoulder and see, when have we done what type of study and who implemented the study. And we also want to register our studies before we conduct these studies. So there's a whole bunch of things actually really copied from the world of randomized controlled trials in order to improve the transparency and therefore reproducibility, and to improve the validity of our findings. Here's an example, stimulants in psychotic episodes, a real-world evidence study exactly following the paradigm that I just told you, the target trial paradigm. You see the study design diagram here, where we compared the methylphenidate against amphetamines in patients with ADHD and studied the risk of psychotic crises. You then get these tables where you have one-to-one propensity score matched patients, 33,825 in both groups. You achieve nice balance between observable patient characteristics. And then, of course, you estimate treatment effects. Here you get a hazard ratio of a 40% or 55% increase after adjustment, or 65% after propensity score matching. So this is a typical process and an example and findings of a real-world evidence study where we might not ever actually have randomized evidence on the relationship between stimulants and psychotic events. Here's another application of real-world evidence, particularly when you have a scalable infrastructure like the software that I showed you in repurposing exercises, where whatever mechanism you have, and these are network analyses, Giulio Scalzo and Albert Barbarazzi, they are specialists in this. I don't fully understand it, but it doesn't matter because this is about working in a team. We come in order then to do cohort studies using our vast databases in order to see whether the hypotheses that they come up with in this here can be confirmed in our real-world evidence studies. And some can be confirmed and others cannot be confirmed. But that is an important step before you start randomizing patients into the treatment groups, so that you actually improve the prior probability that this is actually a causal relationship. With that, let me summarize what I told you. The study design issues are most important threats to causal interpretations when you have non-randomized real-world evidence studies, the big data studies in medicine. So contemplating the target trial, the trial that you would have wanted to do, is a really, really helpful strategy to reduce errors in the planning and implementation of such studies if you're interested in causal conclusions. Measurement issues in secondary data need particular attention. We have to think what, how, and when the items were measured, and whether that in the secondary data, in the electronic health record data, or whatever you have, is similar to the randomized trials that they would have liked to see. And this is where I see many tears flowing, because that's often just not the case. And you have to make a judgment call how close you want to be to the target trial and at what point it is ridiculous, it just doesn't make any sense, and you probably should just stop doing these studies and move over to primary data collection. That really depends on the study question. But the target trial makes these issues very clear to the investigator. If 1 and 2 are fulfilled and addressed, they have a valid study design, they have a very good measurement of the key characteristics, then the confounding control is, in my mind, really becoming a secondary issue. Still, if you compare active users against non-users, the confounding, the selection processes to use versus non-use might be so strong that you cannot overcome that with statistical analysis methods. You need to have baseline randomization. And again, it is important that we recognize that. And let's keep also in mind that real-world evidence is clearly here to stay, and regulators will increasingly consider real-world evidence. So it is important we talk about these issues, that we improve our approach to real-world evidence. In 2019, for example, 60% of the NDAs submitted to CDER for drugs had real-world evidence is part of the submission package, and 12% thereof was considered essential evidence. That is really important to realize, that basically saying that will be replaced RCT evidence. And sometimes there's success and sometimes it doesn't, but you see the movement here. Very exciting. Transparency is paramount if one wants to be taken serious, like with an RCT. Just think of the transparency we have from the RCTs and mimic that as much as you can. Here's my personal prediction that over the next 10 years, we'll learn much more about the validity of real-world evidence. We have already learned quite a bit over the past 20 years in bits and pockets, but I think we'll get a much better understanding still of when it is useful to do these big data analyses, when we want to come to causal conclusions, and how do we do them right. And I'm deeply convinced that comprehensive software platforms will be the way to success here in order to avoid investigator mistakes, in order to ensure transparency, in order to also facilitate transportability of the analytic platform, so that others, your stakeholders, the recipients of your research, can actually reproduce the research that you're doing, something that is essential for getting traction with your stakeholders, with your consumers of your wonderful studies. So with that, thank you very much for your patience, and I'm more than happy to answer any questions. Shoot me an email. Brian knows how to contact me. So thank you very much, and have a wonderful day and conference. Bye-bye.